Hi, everyone. Thank you so much for taking the time to learn about our research project. My name is Shannon Johansson, and I am a graduate occupational therapy student.
My name is Rebecca Victory, and I'm also a graduate occupational therapy student.
My name is Leah Brown, and I am a speech-language pathologist in my clinical fellowship year.
My name is Mackenzie Swinehart, and I'm a graduate speech-language pathology student.
Together, we are a group of occupational and speech therapy student and practitioners who have been collaborating over the past year to develop and conduct a research project titled Barriers and Supports for Compliance in an Intensive Home Program, an Interprofessional Qualitative Study.
Occupational therapists, commonly referred to as OTs, are practitioners that work with individuals across the lifespan to promote health, prevent injury, and improve quality of life. OTs work in settings such as hospitals, schools, outpatient clinics, nursing homes, and many other places. They use their education to create individualized treatment plans that focus on activities people do in their everyday lives, such as bathing, dressing, grooming, eating, and other fine motor skills.
Speech therapists are also able to work with individuals across the lifespan in many different settings. Speech therapists assess, diagnose, and treat speech, language, cognitive communication, and swallowing disorders. Speech therapists may work in educational, healthcare, or research settings targeting both developmental and acquired disorders.
Healthcare professionals often work together in interprofessional teams to help their patients achieve their goals and improve client satisfaction. Research studies have found there is a functional link between the language and motor systems within the brain. This link emphasizes the importance of having speech therapists and occupational therapists work together to provide interprofessional treatment. Before we further introduce our study, we want to clarify and define several terms. A stroke is a disruption in the blood supply to the brain. A left-sided stroke may cause Broca's aphasia and/or hemiparesis. Broca's aphasia is typically characterized by disfluent speech, word-finding difficulties, their comprehension of language is relatively preserved, they usually have more difficulty with verbs than nouns, and their speech is agrammatic. Hemiparesis is weakness or partial paralysis of one side of the body.
Individuals who have had a stroke often benefit from therapy services. Modified Constraint-Induced Movement Therapy, or MCIMT, is an intervention strategy used by occupational therapists for individuals who have hemiparesis. It involves wearing a mitt on the unaffected upper extremity, which forces the individual to use their affected extremity.
Individuals who have aphasia often seek rehabilitation services from a speech therapist. Speech therapists may use verb network strengthening treatment known as VNEST. VNEST is based on the concept that verbs are at the center of our neurological language networks. A verb promotes association between who is performing the action of the verb and the outcome of that action. This association increases overall verbal output.
Speech therapists often utilize a multimodal communication approach when working with individuals who have difficulty verbalizing their message, such as people with aphasia. This approach allows individuals to use different forms of communication in order to accurately convey their message. People may alternate between verbal, gestural, written, and visual methods in order to have successful communicative interactions. Therapists from all disciplines commonly provide their clients with a home program as well.
A home program is a set of exercises or instructions provided to an individual from a therapist that should be completed at home. The purpose of a home program is to facilitate further improvement outside of therapy. MCIMT interventions include an intense home program portion. This is referred to as a transfer package.
Our research study came about after investigating previous research studies that focused on the link between the language and motor systems. Many of these studies commented on a limitation being the lack of adherence with the home programs. We were interested in investigating this further. Our research questions were: what are the barriers, supports, and facilitators to person compliance to modify constraint-induced movement therapy transfer packages when paired with an individualized language treatment program? What would make it easier for participants to adhere to the MCIMT and language transfer package protocols? And while knowing barriers, strengths, and facilitators allow interprofessional clinicians to develop a more effective transfer package. Neuroplasticity encompasses many principles that support the theory that following brain damage, relearning behaviors is made possible through rehabilitation. This is why many people who have had strokes attend both occupational and speech therapy. Neuroplasticity supports that both repetition of a target behavior and intensity, or how many times that behavior is performed, may indicate how well that behavior is relearned. VNEST encompasses multiple principles of neuroplasticity to improve language output for persons with aphasia.
Research has shown that there is a strong link between motor output and language. One study in particular found that listening to action-based verbs enhanced both language output and grip strength. This validates that there is a neurological connection between an action and its corresponding verb.
There have been many studies that focus on MCIMT home programs and the importance of shaping them around an individual's interests. One study found that individuals who participated experienced self-perceived improvement when actively engaging in the home program. In addition to this, involving caregivers in the home program process has been shown to provide further support.
An interprofessional approach between speech therapy and occupational therapy has also shown to improve participant satisfaction. One study that looked at the benefits of using a collaborative approach for individuals with aphasia found that pairing language therapy with meaningful activities created by the occupational therapist led to an overall positive therapy experience. In order to participate in our study, each participant had to fit a certain criteria. Our inclusion criteria required that the person had to have sustained a left-sided stroke, have hemiparesis, right hemiparesis, and Broca's aphasia as a result of the stroke. The bedside Western aphasia battery was administered to each participant to confirm the presence of Broca's aphasia.
Each participant was also required to lift a styrofoam coffee cup with their affected upper extremity and had to score a 25 or higher on the Montreal Cognitive Assessment, or MoCA, to ensure that their cognitive skills were intact. The MoCA assesses aspects of language, delayed recall, repetition, attention, executive function, orientation, and abstract thinking. We had 4 participants who met this inclusion criteria. The activities of each session were determined based on the participants' interest. For example, some participants chose to bake cookies, paint flower pots, work on ADLs, or play a game. To implement MCIMT, each participant wore a mitt on their unaffected upper extremity, like the one pictured on this slide. This promoted the use of the participant's affected upper extremity with the goal of improving motor function of the affected upper extremity.
An individualized speech and language intervention was implemented that incorporated aspects of VNEST. Each participant was encouraged to produce the verb that directly corresponded with the motor act being facilitated by occupational therapy. For example, the participant was encouraged to produce sentences and expand upon them, narrating their actions during various activities. For example, during the cookie baking activity, a participant was required to mix the ingredients with their affected upper extremity while producing, "I am mixing the dough" several times. Multimodal communication, which encompassed whiteboards with written words, verbal cues, and gestural cues, was implemented in order to enhance participant success.
Each participant was also provided a personalized home program to encourage the carryover of skills that were targeted in therapy. The home program involved the participants wearing the constraint during activities of their choice, while simultaneously producing language that correlated to the activity. For example, a participant may say, "I am reaching for the can," while using their right arm to reach for a can on a shelf. Participants were told to document their engagement in the home program in a journal that we provided. 2 group discussions, including all 4 participants, were also held to provide an opportunity for discussion about the barriers and supports experienced with the home program.
Interviews were conducted to gather participants' reflections. Open-ended questions were posed, as well as asking the participants to rate their perceived improvement on a Likert scale. Aphasia-friendly questions were developed and used to aid in the comprehension and response during the interviews. Interviews with caregivers also took place to gather information on the caregiver perspective. Each interview was recorded and transcribed verbatim in order to identify themes. We read through the transcriptions and pulled out prominent statements that we organized into a chart to allow for comparison and identification of overarching themes. The transcriptions were then put into NVivo software for theme extraction.
All participants reported that a home program is beneficial, but they would prefer increased structure rather than an open-ended home program. All participants also preferred interprofessional treatment to individual occupational therapy or speech therapy sessions. All participants indicated a 4 out of 5 on the Likert scale when asked how much they think they have improved. However, none of the participants had actual improvements based on the standardized assessments that were administered. Caregivers also indicated a desire to be more involved in treatment sessions.
The supports identified were caregiver support at home, intrinsic and extrinsic motivation, and increased confidence. The barriers that emerged were lack of structure within the home program, frustration, and inconsistent or incorrect use of the MIT.
During the post-treatment interviews, one of the caregivers stated, "I saw the participant speak more and wanting to speak more, and having a very positive feeling when the participant comes out of the session." They reported that they saw a very positive change in their loved one.
This photo was taken in the YWRI Occupational Therapy Clinic. An occupational therapy student can be seen placing the MCIMT mitt on the participant's unaffected upper extremity.
During the post-treatment interviews, a participant was quoted to report, "Last night we were talking at dinner, and I was able to talk to everybody." This participant reported a preference for receiving occupational and speech therapy at the same time.
This photo was taken in the YWRI Occupational Therapy Clinic. A participant is playing the game cornhole with her affected upper extremity. Occupational and speech therapy students are present providing intervention and support to the participant.
These next slides will be video examples showing the interprofessional intervention with 2 of the participants.
I scooped the dirt on
This study highlights the importance of the qualitative aspects of interprofessional treatment for individuals who have sustained a left-sided stroke. This information gathered throughout the study is useful for clinicians when formulating home programs.